Good evening, everybody, and welcome to the second webinar for Bleeding Disorders Awareness Month. Firstly, a few housekeeping notes. We're recording this session and we're currently live on Facebook as well. Our speakers are happy to answer questions at the end. We will run a live Q&A panel, so you can use the chat feature to pop your questions in, and we'll feed them through to the panel. Bleeding Disorders Awareness Month is a time for us, our community and stakeholders to take part in activities and raise awareness about haemophilia, von Willebrand disease and related inherited bleeding disorders around Australia. The theme of our month is One Community, Many Faces. We will showcase different topics for all ages and stages during the month, and don't forget to keep an eye on our socials and our website. Tonight, we're going to talk about new therapies in the bleeding disorders space with a Q&A at the end. Our speakers tonight are Dr. Liane Khoo, Haematologist Director, Royal Prince Alfred Hospital, Dr. Sally Campbell, Haematologist, Royal Brisbane and Women's Hospital, Stephen Matthews, Clinical Nurse Consultant, Royal Prince Alfred Hospital, and Sharon Karras, HFA Executive Director. So I will hand over to Dr. Khoo, and you're ready to go.
Thanks, Natasha, and thank you, HFA, for inviting me to, give this talk. So, as Natasha said, my name is Dr. Liane Khoo, and I'm a hematologist and the Haemophilia Treatment Centre Director at the Royal Prince Alfred Hospital in Sydney. And so the idea of this webinar really is to just give a very quick overview of, some of the new therapies for the treatment of haemophilia, because it's a really exciting time, I think, we are at with all these new treatments coming up. And then really to have a good, discussion about these therapies. What does it mean for patients? And, let's get the conversation going with your haemophilia treatment center about what these therapies mean for you and where, what you can do. So I'm going to just give a brief overview on some of the new therapies, but really want to think about, where we've come from in terms of, how we think about the treatment for haemophilia. So you see a lot of things talking about prophylaxis. It's a standard of care for patients with haemophilia, and we're very lucky in Australia that we do have access to prophylaxis. So in 2014, one of the definitions for what prophylaxis means is actually the regular intravenous, and highlighting the word intravenous, infusion of a missing clotting factor. So you're giving, what you're missing intravenously, and with the aim of really to prevent bleeding. But just in a very short time of 6 years, we've actually, with the advance of science, managed to change how we want to think about prophylaxis for the care of patients with haemophilia. So in 2020, the new WFH guidelines for the management of haemophilia came up with what the definition of prophylaxis as the administration of hemostatic agents. So not just intravenous, but just an administration of agents that are not only factors with the aim of preventing bleeding, but importantly, I think the focus now is that we can actually allow patients to lead active life and achieve a quality of life comparable to non-hemophiliac individuals. And I know it's just a few words, a few extra lines, when you put in the definition, but I think that really represents a whole a whole paradigm shift in how we think about how we want to address treatment for bleeding disorders, and with the technologies we actually can. So a lot of you will be familiar with how the evolution of haemophilia therapies, and I'm putting this in because I think it's very important to understand, where we've come from and appreciate what we have, but also a lot of patients who have seen family members grow up in an area where there's only blood and plasma and cryoprecipitate available. And then a lot of patients had to live through the, era where there was a lot of viral contamination, risk of hepatitis, HIV, and then being able to then have safe recombinant factors in the 1980s and 1990s, and really be able to think about home treatment, but still have the burden of having to intravenously inject factor treatment. And it was really probably, in the last 20 years that we've had access to things like extended half-life factor concentrates, which allow fewer injections and allow us to think about how can we actually improve the quality of life for patients. And then really in the last 10 years, really thinking about these new novel therapies, which I think we're all really excited to hear about, this concept of non-factor replacement, antibodies, gene therapies. So we're really thinking beyond factor concentrates. And this is what I guess this evening session really is trying to look at, what these new, treatment options are available for us in the bleeding disorders community. So what I have, a lot of patients might already be on this. So this is what we currently have available, and this is the technologies behind how we can actually achieve these fewer injections and extension of half-life. So one of the things that we have is this thing called pegylation. So it's adding like a sugar molecule, like a polyethylene glycol onto the factor 8 or factor 9 molecule, in this case factor 8, which we have adenovate. You have the factor 8 protein. We add on all these sugar molecules onto it, and because they're bigger molecules, they're not cleared as quickly by the body. If it lasts longer in the body, that means it translates to fewer injections. I've also put up these couple of pictures showing that, that people be very familiar with what the current it's powder, water, and you inject, and it's also safe in terms of pathogen safety. It's manufactured in a vat and it's synthetic, so there's no risk. A lot of people worry about the viral contamination. There's none of that. And also this technology is not new. A lot of some other drugs used in treatments of other diseases have also used this technology. And we currently have this has been available for at least the last, 6-7 years. Other ways of making the factor 8 or 9 last longer is either attaching other molecules onto it, like this thing called the IgG-Fc receptor or albumin, and that helps the factor 8 or 9 circulate longer in the body by harnessing the body's natural recycling pathway. So instead of being cleared by the kidneys, it sort of hangs around the body a bit longer. Same concept, if it hangs around the body a bit longer, that means you don't have to inject as frequently. And here we have currently available in Australia 2 products, Eloctate for hemophilia A and Alprolix for hemophilia B. Again, very similar concepts of water, powder, injection made in a vat. And I think, when I'm talking to my patients, this is not that hard concept to think about from the current factor. What we also have currently in clinical trials, and this is an exciting product that has already what we call reached stage 3 clinical trials, meaning that most of the safety and efficacy data have been collected, and we have in this case is factor 8. So you have factor 8 molecule, and it's linked to all these other proteins to make it last a lot longer in the body. And then what you can see here is that on once-a-week injections, so it's still intravenous injections, but on once-a-week injections at the end of 1 week, you're getting factor 8 levels of around, 12-15%, which is very much like, what a mild hemophilia patient with hemophilia A is. Then what about the non-factor replacement therapy? So what we currently have using this technology is something called Hemlibra, which I think a lot of you would be familiar with. And just very quickly to go through the concept. So in hemophilia A, you're missing the clotting factor, factor 8. So what factor 8 does, if you cut yourself or have a joint bleed, factor 8 goes to the site of bleeding and gets together all the other clotting factors to help you form a clot to stop bleeding. In hemophilia, you lack hemophilia A, you lack factor 8. So when you give yourself either your normal, your factor 8 replacement or the extended half-life factor 8, it replaces the missing factor 8, so you have a clot. So you'll be able to form a clot to stop the bleeding. What Hemlibra is an antibody that does exactly the same job as factor 8, but doesn't look at all like factor 8, as it's an antibody, again, manufactured synthetically, so no risk of viral contamination, and it does the same job of factor 8 by bringing together all the other clotting factors to form a clot. And because it's an antibody, it's a very small molecule, it means that it can be given under the skin. So it restores the function of missing factor 8. It can be given in patients with hemophilia A with and without inhibitors. And because it's under the skin, what you get is a very steady state level. So it's absorbed slowly, you get it, it stays in the body for a long time. So you don't have the high, peaks and troughs that is required when you have your normal factor 8. And that has pros and cons. Some people like the idea of having this constant steady level on once a week, once every 2 weeks, or once a month injections. You constantly are protected. Some people say they rather have more control and want to be able to inject their own factor 8 because they want to have the peaks when they're doing high level activity of sports, and then not have to inject as frequently if they are not as active. So it's really a personal choice of how you want to do it. But the good thing is that we do have these treatments currently available. What else is also available? So we've also got these concept of non-factor replacement therapies, and it's being called like rebalancing therapies, and I'll explain a little bit why. And currently these products are not available, and they're still in late stage clinical trials. But the concept of these therapies is that in patients without hemophilia, we have a nice balance of procoagulants and anticoagulants. So you have enough procoagulants like your factor 8, factor 9, factor 11, factor 10 to help, form a clot so you don't bleed to death. And then you also have, on the flip side, to balance it, anticoagulants to help dissolve the clots so you don't get the problems of lots of clots in the legs and in the lungs, like the airplane syndromes. And this is in a really nice balance, so you have enough things to stop you from bleeding, but also enough factors then so that you don't end up having too many clots. Unfortunately, in patients with, say, for example, hemophilia A or hemophilia B, you're missing factor 8 in hemophilia A and factor 9 in hemophilia B. This balance is tipped to the side of having, fewer procoagulants, so you end up bleeding more, and then you're not able to form a stable clot. What these new therapies do is that they actually they take away some of these anticoagulants, so you kind of restore this balance. So instead of having that balance tip too much to the side of bleeding, you then rebalance the scales by taking away some of these anticoagulants, and so patients then don't have the problem of that bleeding imbalance, and you kind of have better ways of more able to form a clot. And we've got a couple of patients on different, of these agents, and who are doing, really well. And the important thing about these things are that they're given subcutaneously, again, under the skin. Some of them are given every day, some are given once a month, but it makes a huge difference not having to inject, intravenously, having to find veins and, have to go through that whole process. But apart from these new therapies, I think hemophilia is changing a lot, not only in terms of treatment, but now we have to start thinking about, how else, with patients and their family at the heart of all these things, apart from your hematologist, do we need to think about how can we utilize telehealth, psychologists, patients are growing older, getting geriatricians, having other comorbidities, heart doctors, liver doctors, how can we make sure that these therapies are available to patients who live, all throughout Australia, because this is an exciting time of hemophilia with these treatments. How can we then, bring everybody along on the journey? So that's my bit on the new therapies, and I think I'll now hand over to Dr. Sally Campbell to talk about some exciting things happening with gene therapy.
Just checking that that's all working. Thanks very much to HFA and to Liane for that great talk on the non-factor replacement therapies that are there. I'm Dr. Sally Campbell. I'm the acting director at the moment for the Royal Brisbane Haemophilia Treatment Centre in Queensland. And it's a pleasure to be here today to talk to all of you online about the new therapies. I think all haemophilia treaters often always reflect on the past. And I think that's an important place to know where we started, which is what Liane's gone through already about what treatment used to look like in the past. What I think we also like to highlight is that two 2/3 of the world's population actually do not have access to clotting factors because the cost of treatment is too high. And I think it is part of our job as a country that is fortunate enough to have access to factor VIII, that we think about how we can enhance care for those regions and other centres. And I think a lot of that we already do as organisations, but it's something that I often think about as what can I do to help those patients who don't have access to factor. And certainly with the current therapies, there is a lot of choices. And there are some psychological things that come when you are presented with many choices. And although we often talk about how great it is to have a lot of choices now in haemophilia when we didn't before, it is actually sometimes a bit of a burden for patients when we present them with multiple different options of treatments they can go on as to know which one is exactly right for them. And I think a lot of that is about having often several conversations with your haemophilia treatment centre to allow you to know which one might be the right one for you. And the right one for one member of your family may not be the right one for another member, depending on what their preference is and where they put their sort of personal values on each of the treatments. And these are the non-factor ones that Liane's already sort of gone over. So I really wanted to focus my part of the talk on gene therapy, which I think is a really exciting thing. And I think a lot of my own patients are coming up and asking me questions about it. And I think when you Google it, you can get a whole lot of different information. Just specifically thinking about haemophilia gene therapy, there's been 4 main ways that each of the research and scientists have been pursuing to see ways that we can improve care for haemophilia. The one that has really taken off is that one on the top left there, the viral vector mediated. But each of the other ones are actually still having ongoing research done into them to see if they can offer potentially better options for delivering gene therapy. And when you think about gene therapy, and if you do Google it, you're going to find that a lot of diseases are having increasing data and increasing products becoming available to them, not only for haemophilia, but for many other diseases as it's being pursued. And unfortunately, if you pull out each of those different ones, their specific things will not apply to haemophilia. So I think part of the role in this space is to make sure that if you do find information, it may not actually be relevant for haemophilia. But just speaking about haemophilia, about how we went about thinking about replacing it, as you can see on the end, there's actually quite a number of different ways that you can think about modifying genetic material within someone's cell. The most simplest way to think about it is, and that's the option A, which is what has happened with the vector, is that by putting in a replacement gene within the patient's cell, you then allow protein production within the cells. There are other ways. And so for some other diseases, they actually want to stop protein production. So you have something that will knock down that gene within a patient. In others, and if you see things like zinc finger or Casper or CRISPR on any of the things that you read, that's talking about editing someone's gene to change where the mutation is to replace it with the correct sequence of events. Similarly, with the transgene is when you can put a piece of DNA into somebody else's DNA, and non-coding RNA I won't speak on because it's reasonably complicated and so far is not something that's involved in haemophilia. When we think about all of the trials that have come out in the haemophilia space, most of them have used the same vector. That is, they've used something called adeno-associated virus, and most of them have gone with number 5. So there's actually 8 of them in total. The reason they've gone for this one is that this virus itself has no pathogenicity in humans, even in its wild type form, because you have to get the virus at the same time that you get adenovirus. And adenovirus is a cold virus, but adeno-associated virus actually doesn't cause any symptoms when you have an infection on its own. It's also what's called episomal. That is that all viruses use our machinery when we get infected with them. So the viruses are very small molecules that don't actually have a whole cell structure and they can't make their own proteins. So what happens when they get inside us is that they use our machinery to make their proteins. And so it was through this kind of power of the virus that gene therapy with vectors came about, in that we replaced the viral DNA with the DNA that's missing in either haemophilia A or B. That then hops inside the cell and your cell starts producing it. But with AAV, it doesn't put that DNA into your DNA. It actually sits just outside it. And I think that's one of the strengths of haemophilia gene therapy. And I can talk a bit more about that in a moment, but it does have very low integration rates. That is 0.1% of cells will have a small amount of DNA put into it. So it's not 0, but it's very low. And part of the reason I think they chose this particular vector is that, and one of the things that's quite ongoing in the research space is that how often have people already been infected with this virus? Because as it stands at the moment, if you have been infected with the virus, you will make antibodies against it. And although it's still ongoing research into this space. Currently, most of the gene therapy trials mean that if you do have antibodies to that virus, that is, you've seen it before and you will have no idea that you've seen it before because it doesn't give you any symptoms, you can't have gene therapy, because if we use that as the vector, if we gave that to you, your immune system would just wipe it out and you wouldn't actually have the result that we're after. So this data is a little bit old. It's from 2010 and 2012, looking at how many people actually have antibodies against it. And so AAV5 is the one that most vectors are using. You can see that 20% on this population had already had antibodies against it, and a little bit higher in the pediatric population had, whereas the general population was much lower. And the reason for that is thought to be that, unfortunately, patients with haemophilia are in and out of hospitals, and it's likely that they may have, unfortunately, caught more viruses without knowing within the hospital structure. Given that a lot of things have changed in the last 12 years, there is increasing data coming out to see if those numbers are the same. But roughly to patients, I often quote that maybe there's up to a 40% chance that you may have already seen this virus and therefore you won't be eligible currently. But what I would say is that itself is also being challenged, with one group in particular dosing patients who have antibodies, but low amounts of them, and successfully doing it. So I think even that, which originally when the first trials were coming out, it was if you have the antibodies, you can't have gene therapy. Even that decision point has now changed in the 10 years that gene therapy has been happening. And so 2011 was the first paper that was published from the UK group that dosed the first patients. And now there has been EMA approval of the first agent for haemophilia A, that is the European Medical Association has approved it. It's called Roctavian, and it's made by BioMarin, and they're currently reviewing another agent for haemophilia B produced by CSL. And so I think in that short 11 years, we've come a long way in the research space. And this is through the clinical trials that went through the phase 1, phase 2, and phase 3 to make sure that each of these medications is safe and efficacious. And in therapy, what that means for Australia is that several haemophilia treatment centres in Australia are already participating in these clinical trials. And I've listed the ones there that are active sites and participants. And the Australian Haemophilia Centre Directors Organisation is soon to release a roadmap to gene therapy for Australia to highlight this complex issue. And I think we have all been thinking about what this is going to look like in the real world when it comes out of clinical trials, and what it's going to mean for patients and how patients are going to access it. There are several roadblocks that will be highlighted in that roadmap, which I think are important to know ahead of time. And some of that is around funding. And I think the biggest thing, though, for this group, and I'm sure this is what a lot of you have interested questions about, is what does this mean for you? And what are the eligibility criteria for each of these medications? How long is it going to last? And what factor level am I going to get from this gene therapy? And then the concept of genotoxicity is something that we are all very mindful of. And genotoxicity refers to when you have any therapy involving your genes, is it possible that it will cause an adverse event, in particular cancer? And I guess I might just briefly touch on a few of the eligibility things, and I think this will be more answered in the Q&A session when we have the chance to have a chat about it. But what I would say for eligibility as it currently stands is that it is currently eligible via trials for patients who have severe haemophilia A and B who do not have inhibitors or a history of inhibitors. And the eligibility criteria are quite extensive, and I would suggest that you talk to your haemophilia treatment centres for those that have active trials happening for recruitment. But in principle, at the moment, the biggest thing is about the liver. So the way that your liver is the primary production site for factor VIII and factor IX. And so this gene therapy targets the liver. So basically we're infecting your liver with the virus that contains the gene. And as such, all of the scientists and the clinicians are very mindful that we want to make sure that people's livers are in good condition before they get dosed with this. And due to that, some of the criteria that means you're not eligible is if you do have liver disease that would not make it safe for you to have this. And then there are a series of other eligibility things to think about, but I think the liver is the main one. In terms of durability, that's also quite a difficult question to answer. And we are all thinking about that quite a lot within the HTC director community. So far, if you look at the data that goes out, it's variable between the different trials, but we have up to 6 years after the first people with the new generations of gene therapy have been dosed who have gene expression ongoing. And the level does depend on whether it's haemophilia A or B, but it's roughly somewhere between 10 and 20%. So that is, they've had their gene therapy 5 or 6 years ago, and they're still producing factor VIII or factor IX at around about 10 or 20%. Within that group, though, there's a wide variation. So some people have actually production that's above 50% and others will have that's less than 10%. And so far, we can't tell you which person you're going to be, whether you're going to be somebody who's going to have expression that's at 100% or whether you're going to be somebody with expression of 5%. And I think that's a really complex thing to talk about. And I think it's something that I would suggest that you have several conversations with your haemophilia treater about before you undergo something like gene therapy, and have a good chance to think about it within your own family and your own construct as to what that would mean. And I think that when we might get onto a bit more in the Q&A session about what would classify as a success for gene therapy. And I think that actually is really patient specific, because I think what would be classified as a success for one person would not be for another. So I think it really is person dependent as to what a success would be. And so I will halt myself there because I tend to just keep talking, and then maybe we can go to the question and answer part.
Thank you, Sally.
So we might go to the question answer session now, but what I might do is just share my screen. So
thank you. And Stephen and Sharon, would you
Yep.
like to put your cameras
Sally, I'll
on,
get you to
please?
stop sharing if that's okay. Yep. Cool. Yep. So I guess in this question answer, I encourage all of you to, please make, put questions in the chat and Facebook, because the aim of this session really is about, for you guys as patients, what do you want, from us? So I thought one of the things really would be, what do you and your families, want from us as treaters, as nurses, as, as part of the foundation, to help you make informed decisions about these new therapies. As Sally mentioned, sometimes it's hard when you're faced with so many choices, which one is, the best one for you at this current time, because, previously it was quite easy, you have factor. You might change your brand or factor when the new tender comes up, but it's still factor 8 or factor 9. Now we've got these whole lot of different treatments, each with their own pros and cons. And so I want to get people to really start thinking, what do you want from us to help you make these decisions? And I think one question came up in the chat. So I think it's for Sally. And I know you spoke a lot about the liver and a bit about the liver, but is you mentioned the AAV5 vector, is that the one that targets the liver?
Yes, it does. And so all of the ones in haemophilia A or B target the liver. And so they have sort of promoter regions on them that mean that they primarily infect the liver. The virus does get throughout the rest of your body. So it gets into your blood, and it also gets into your urine, your poo, and also into bloody products like semen. But the area that it's aiming to affect is your liver. You actually do clear it from the other parts of your body with time. But that's why we've put a lot of focus on the liver. And what I forgot to mention, which is an important part, is that it's very much not a one injection and done kind of model. Although that's the idea of it, is that you have one injection and it will give you a factor response. It actually afterwards, it means there's quite a lot of tests that happen afterwards. So for a patient, it may look something like an infusion followed by weekly blood tests for probably 6 months. And then depending on those blood tests, they may have to start on something like steroids to help their liver not basically kick the virus out.
Cool, thank you. So I'll ask this question to Stephen. If patient comes in, they're having to talk to you, they drops by having the usual factor product order and says, hey, I just read on my Facebook feed about this new gene therapy. Can I have gene therapy for my haemophilia? What would be your advice to these patients, Stephen?
Well, as like Sally alluded to, at the moment, we're just going on the trial guidelines. So we don't know if and when it does become commercially available, what sort of guidelines there will be. But what I would suggest was, when these things come out, especially in the media, lots of times they're quoted as being a cure. I mean, in my opinion, this is not a cure for haemophilia. And that's where I'd start my conversation. Because if you're going to have a family, we're not changing your haemophilia as such, because you can still pass that on. So in my terms, it's not a cure. It's just another treatment. And it's changing you from your severe to most likely a mild version. But again, it would have to come into like lifestyle. And there's going to be a lot of commitment. As Sally said, like, we're going to be wanting to do, well, at the moment, at least 6 months of weekly visits to your centre, because you want to test what your liver's doing, what your factor levels are doing. Another thing is, because at the moment it's aimed at adults, I don't think anyone has considered using it in children. You've got to commit also to probably a year of abstaining from alcohol if you like to have a drink occasionally. So there's a lot of factors that you've got to take in. It's a lot of commitment. And if you realise all of this, then we'll say, yes, we will support you, but it's going to be a lot of commitment on your part, on our part, to make it a success.
Okay.
Is that what you're aiming for?
Yep. Yeah, I think it's really just, let's have that conversation, because it's not just as you said, it's not just a single injection. You're cured from haemophilia. You don't ever have to come to the haemophilia center again. It's a lot of, I guess, monitoring to make sure it's safe, but also, that it works. Yeah, thank you. So I think we've got another question. I might ask Sharon this one. So it says, what do you think, is the time frame for patients to get, access to, gene therapy that's going to be funded, and what are we doing to try to, advocate for that?
Thank you, Liane. I suppose the first question, or the first comment to make, is that no gene therapy is registered in Australia yet. And so that the people that you're hearing about are people that have had the benefit of, or have contributed to clinical trials. We're grateful for that, of course. But in terms of timeframes, we've seen in the past the processes that new medicines need to go through, and we won't go sort of into the detail, but there are several assessments that the government committees do in order to evaluate whether a product, well, actually I should go back a step further. The regulation, so the Therapeutic Goods Administration needs to have an application from a sponsor, from a pharmaceutical company that's produced this medicine. So we have to have an application in place to the Therapeutic Goods Administration, and following that process, once the product is registered, or sometimes simultaneously with the registration process, the other parts of government can start to assess the treatment product for whether it can meet requirements to be funded. And there are a whole lot of bureaucratic aspects to that, and some of it is around the cost or the likely cost, and then how that's going to fit into the current picture of haemophilia products. And as many of you will know, that our treatment products are managed under the National Blood Arrangements, which is a National Blood Agreement, which is a cost-sharing arrangement between all governments. Now, HFA has, to this point, expressed its view that the gene therapy, for example, ought to be within the National Blood Agreement and those arrangements, but it may not be the case. And so we have to have a lot of discussions with governments and all the stakeholders about where that's all going to fit. So with some of the medicines, they've taken sort of 2, 3, and 4 years from registration through to when they've become available to patients. So it's really important that patients are having discussions with their clinicians and their health service providers to start to sort of think about what they're wanting. But the other side of all of this is that I think there's going to need to be a fair amount of advocacy so that we understand what patients want, so that we can communicate that to governments so that they can take that into account when they're making these decisions. So I can't give you an answer of time frame, but it's not short. There's a lot to be done for the assessments.
Thank you, Sharon. We seem to have just lost Liane. She dropped off, so that's fine. I'm hoping she'll join us.
I can see there's another question from the group that I can answer. Which one? Or from Facebook that says, it's asked the question, if I've had Hep C and have been cured, can I have gene therapy?
Yeah.
And that is a slightly complicated answer. The short answer is yes. If your liver is showing signs that it's functioning normally. So if you have had Hep C and it's been cured with treatments, and your liver assessment, which has involved both a special ultrasound and blood tests, demonstrates that it's healthy, then you can have gene therapy.
So I might then ask you, Sally, if I'm thinking about going gene therapy and all these issues about Hep C, my liver health, what can I do now to prepare myself? Because as Sharon was saying, it's going to be a while. So gene therapy is not happening tomorrow. So I've got some time. How do I prepare myself or my liver so that I can, participate to, get gene therapy?
It's a very good question, Liane. I think, and one of the, apart from, I guess, the things that are outside of our patients' control, that is that they got, HIV and Hep C, the biggest issue actually that's facing the world at the moment when it comes to liver is actually non-alcoholic fatty liver disease. So that's estimated to affect 1/3 of the worldwide, all participants, everyone, that's everybody. And so things that you can have to reduce that, I guess, is to have a moderated alcohol intake. And so you can ask your GP about what's recommended for alcohol intake, but largely that means 2 alcohol-free days a week and no more than 2 standard drinks a night. And then otherwise, things like lifestyle, health, and weight are very important. So where possible, aiming to not be overweight or have some weight reduction strategies if you are overweight already, and being as active as you are able to be with your other comorbidities that may be there. And the other thing in my back of my mind is, is avoiding some of the, where possible, some therapies that might be slightly hepatotoxic. So whether that's an option or not, but if you are presented with, say, 2 options for a drug treatment, you could always ask your provider about the fact that you're trying to keep an eye on your liver. That's a short answer, isn't it, Liane?
Yeah, no,
Sorry.
I think that's perfect. I think the main thing really, from listening to attending conferences and meeting is that, I think as you mentioned earlier, the liver is going to be like the main workhorse that's going to be producing your factor 8 or factor 9. And so it's already going to be under stress. So whatever you need to do to make sure it's in the best health possible and protected as much as you can so it can actually do its job. And I think it's having, thinking about it now, having a conversation with your hematologist saying, are these, is my liver going to be a problem? Exactly what you said. I had Hep C in the past, I'm cured. Is my liver much damage? Before I even want to think about gene therapy in a few years, should I start engaging with my liver specialist again to get it assessed, check out, get ultrasounds, get liver tests to see what's, can be done, to prepare, get my liver in a good enough state. I mean, the other thing I think we were talking about earlier as well, Sally, was apart from just the liver health is the mental health, because a lot of these things, some of this treatment I know you spoke about in your presentation, you might need to be on steroids or immunosuppression to help to stop your body from reacting against the virus. So if that's, and being on steroids, can affect your mood, anxiety, and I think being able, if you already have some, have some problems with mental health and struggling with certain things, having additional stress of a new therapy and steroids can really, add to, the burden. And I mean, this is mental health month as well, apart from bleeding disorders. So I think it's very important that we highlight that, patients come from a lot of different backgrounds, lead normal life, has normal life stresses. And then to throw in all these uncertainties about gene therapy and medications, it's something, again, it's have that conversation with your hematologist, your GP, and start, because I think mental health is going to be, a big thing. We've got time to start, working on this, because a lot of things like the liver, the mental health, cardiovascular risk factors are not going to be fixed quickly. And it's, and it's also good general health, regardless of whether you're going for gene therapy, or not.
Absolutely, I agree, Liane.
Yeah. So another question for Stephen. So a patient, our patients that come in, you've seen them for years. Go, I'm too old for, I've been here for ages. Am I too old for these new therapies? Am I too old to start prophylaxis? I've been on demand forever. My joints are already badly damaged. Do I bother with these new therapies? Do I bother with gene therapy?
Well, I mean, no. Despite the older population in haemophilia, yes, there may be damaged joints, but not all of their joints are damaged. I haven't seen one person walk in yet that every joint is totally damaged. So yes, if they're happy to go on to one of these newer therapies, I would suggest yes, because as we know, even with prophylaxis on standard products, ankles have still been a problem. And we really think that's because of microbleeds that we don't really know that they're happening. So even if I've had a knee replacement, this ankle's fused, I mean, we've still got these other joints, etc., that haven't been affected. And I would suggest that if you want to try prophylaxis on one of the longer-acting intravenous therapies, or if you're eligible and you want to try something like Hemlibra, which is the subcutaneous version, yes, go for it, because we can still stop those little microbleeds that will still affect you. And by changing onto a newer therapy, instead of just, okay, I've had a bleed, I'll now treat it, we can prevent those. And it just means that overall, you'll have less pain, a better control of bleeding, and you'll just find your daily living is much better. So if someone's prepared to change from just treating on demand to going on to a more permanent regime, I would support them 100%.
Yeah, I think we've had some conversations with our patients along those lines, and I think we can't fix the damaged joints, but we can definitely make life better. We can improve either injection frequency, we can prevent bleeds, and overall make life, better than what your current therapies, are. So again, I might ask this other question to Sally again, and I can talk a little bit about it as well. So it kind of goes along the lines of, should I go for gene therapy now or wait? So if I undergo gene therapy now, will I be eligible for another gene therapy down the track if different technologies change? So is this my one, should I go for it now and have it, or should I wait for better gene therapies to come along? Or if I have injection now, if it doesn't work, can I have another one?
It's a very good question. And I think actually I can't answer that question for patients. And when I talk to them about gene therapy, this comes up to say, should I enroll in this trial now, or should I wait until it comes onto market or something better comes along? And I guess the way I answer that at the moment is that currently all the clinical trials are in phase 3 and I think are about to close and to take their product to market. So I think we are actually at that point where we are not reaching the end of technology of gene therapy, but certainly into the safety and efficacy portion. I think currently as it stands, once you've had one dose with gene therapy, as it stands right now, you would not be able to be redosed because you have such high antibodies against that particular vector. Now, given how much things have changed in the space of gene therapy, I actually can't tell you that that's going to be the answer in 5 years' time. And I know that based on the other conferences and seminars that we go to, Liane, that people are working quite hard to see ways that people could be redosed if they lose their factor expression. So I think as it stands right now, no, you can't be redosed. But I think that is likely to change and people are trying to work towards that. And whether or not you go for it right now, I mean, at the moment, the only way you can access it is via clinical trials. And in 2 or 3 years' time, it may be available in the HTCs. And I think that would have to come down to where you are at that time in your life, because it might be that now is the time that you would like to have a try of this therapy. Or if you think, actually, I'm not in a rush, I'm happy with my therapy as it is now, I might like to wait to see if there's something else that's going to come in the next 5 years. I think that's also a perfectly reasonable decision. But it has to come from the person. I think my job, I see, is to say, these are all the options I have for you, and these are the ones that I think are safe for you.
Yeah, I think I agree entirely, because it's kind of, there are known things that we can talk about, like we can tell you what the clinical trial data shows and side effects potentially, but is it going to last 5 years, 6 years, 10 years? Again, we don't know. I think initially, who would have thought that, 10 years ago we'd be thinking about having this webinar about gene therapy, for patients. I think, we wouldn't even think about it because we're still very much in the research phase of it. So I think it's really where you are at your point in life now, and where you are and what your commitments are, in terms of work, lifestyle. Steve mentioned, are you prepared to give up drinking for a year? Do you need more time to get your liver health sorted? All those kind of things. So Sharon, if a patient came to HFA and said, all these new therapies are coming about, I'm so confused, do I go for a non-factor replacement, do I wait for gene therapy, what are the questions I should be asking, what are the questions I'm supposed to be asking? What would you tell them? I'll ask, advise them.
Well, I think sometimes people might be a bit disappointed when we say it's not our job to make a recommendation about a treatment, because of course that's not the job of HFA. But what we do see as our job is to make sure that a range of treatments are available for people, and that we can do some of the work and the advocacy behind the scenes so that these treatment products are available. But we would be encouraging people to go to their haemophilia treatment centre. Now, we know that because treatments have been as they have been over the last few years, people don't have to go to their treatment centre as often. They don't necessarily feel that they have sort of a confident relationship or a relationship with somebody at the centre that they feel that they can sort of have this sort of conversation. So what we would be suggesting is that people really start to think about what they need to know, but start to just make sure that they've got those relationships established, because it's not going to be a one-off conversation. It's going to be a sort of an incremental thing. You're going to be having lots of questions after the first discussion, and it's going to go on for quite a while, I would think. So starting to think about booking in appointments and having some of those early discussions. People that live a bit further away from haemophilia centres aren't often going into the centres. Liane's mentioned telehealth, and we've got more confident about telehealth because of, I suppose, thanks to COVID. But maybe use those sorts of services so that you can start building your own knowledge. But the other side of it, of course, is that there is some experience in the patient community now because of clinical trials, so some Australian experience. And it's worth at the meetings of the haemophilia foundations, the state and territory foundations, to talk to other people, the other members, of what their experience has been, and just to hear. Everybody is different, so you're not going to be able to repeat the same experience, but hearing about the experience other people have had is really helpful. And we'll try to share some of those experiences as time goes on so that people can have the benefit of that.
Perfect. Yeah, I think it's really now's this time to start that conversation, because it does take, build that relationship with your HTC, with your liver specialist, your, psychologist, and start having that questions, because it's, I guess, the good thing I think about gene therapies or these new treatments is that we're lucky in Australia that we have good, safe, effective treatment currently. So we don't need to rush into making a decision to change therapy. So we can start having this decision to make informed, shared decisions with, with patients, the treaters, and your families. Yep. Did you have anything else to add, Steve, Sally?
No, I agree with that. Because we get the patients coming in, and I mean, especially with me, they'll have a chat about what's new, what should I do? I said, well, I'm not going to tell you what you'll do, but here are all the pros and cons. And then next time they come back, they might have okay, well, I've thought about it and I might have to go that way. So, but as you said, because we have got good treatments here, it's not quite such a rush, but for some people it is, and we'll facilitate what each person wants.
Cool.
Yeah, I agree.
Good. I think it's just one more quick question about, do these new therapies have an anti-inflammatory effect? I don't know, my thought is that I don't think it directly is an anti-inflammatory effect, but if you stop the bleeds, then you stop the whole inflammation of, blood in joints, in muscles, and, whole inflammatory process in that sense. So if you have a good factor level with either gene therapy or the non-factor replacements or Hemlibra, all those things, I think if you stop the bleeding, you stop the inflammation, stop the bleeds, then you stop having that whole really, inflammatory response when you have blood in places where they're not supposed to be. Yep. Okay, I don't think we're coming close to 9 o'clock in Sydney and Melbourne and 8 o'clock in Brisbane. I think, if there are no other questions, we might bring this to a close. And I'd like to thank, all of you for joining, in this evening. And I'd like to thank the panelists for, giving up their evenings to have this chat. And I think it's a really nice, I'm hoping that this would be a good conversation starter for you to have to think about, what are the questions you want to do? Start having these conversations with your hemophilia treatment center. Start having these conversations with your family so that you can, make, have that relationship and make these choices, because it's we want everybody along on the journey. So I might hand it back to Natasha just to, if there's anything else she wants to add.
Yes, no, thank you everyone for joining. The webinar will be available on Facebook and on YouTube in the next few days as well. And the slides too will be connected to the YouTube recording too. Thank you. So I think the takeaway is, for more information, contact your HTC and speak to them. There's information on our website as well too, if you like to go there, www.haemophilia.org.au. Thank you to our speakers. Thank you everyone for joining. Good evening.
Bye-bye. Thank you.
Bye, everybody.
Bye.